Hello, I am Dr. Shailendra Singh, Associate Professor of Medicine and Director of Bariatric Endoscopy and Advanced Endoscopy at West Virginia University. Today, I am delighted to discuss our recent article titled Endoscopic Suturing to Prevent Migration of Esophageal Fully Covered Self-Expanding Metal Stents, a randomized controlled trial. This was recently published in Gastrointestinal Endoscopy. This study was conducted at West Virginia University, Ruby Memorial Hospital, Morgantown. Fully covered esophageal stents are commonly used in practice for management of benign and malignant strictures. Stent migration rates up to 60% have been reported in literature, leading to complication repeated procedures and increased healthcare costs. There is a significant cost that is also associated with the use of esophageal stent. Therefore, we also performed a cost effective analysis in this study. In this prospective study, we also standardized the suturing technique, since in all previous observational studies, highly variable stent suturing techniques were used. We performed stent suturing using a over-the-scope suturing device mounted on a double-channel scope. However, a single-channel suturing device can also be used for stent fixation. Suturing is initiated 1 to 2 cm proximal to the esophageal stent. The scope is maneuvered to obtain deep bites into the esophageal wall. We avoid using the helix device. However, suction may be applied to facilitate deeper tissue capture. After an initial bite in the esophagus, the second bite is taken through the stent. Another bite is taken on the esophageal wall, followed by a bite through the stent. In total, 2 bites are taken on the esophageal stent at separate locations. Additional bites are subsequently taken on the esophageal wall, and then the suture is cinched. The suture is cinched loosely to allow for stent expansion and movement while still preventing stent migration. We used a total of 2 sutures. After completing the first, suturing is then performed on the opposite esophageal wall using a similar technique. Care should be taken to avoid crossing the sutures. This can be done by pushing the anchor exchange out to check for any crossing and by ensuring the suture is loaded on the same side as the intended bite. Here you can see the final image with 2 cinches placed on opposite side of the esophageal lumen. Our study is significant as it clearly demonstrates that endoscopic suturing significantly reduces the migration rate of covered stents. Prior to a study, the evidence was limited and largely observational. Our trial adds robust, high-quality data supporting the routine use of endoscopic suturing to secure these stents. Moreover, our study also showed that using endoscopic suturing for stent fixation is cost-effective. Our study shows that unsecured esophageal stents are associated with high migration rate. This highlights the need for innovation in stent design and other devices to prevent migration. Currently, endoscopic suturing and over-the-scope clips are available devices to prevent migration of stents. But a prospective study directly comparing these two approaches is needed. Additionally, further refinement and standardization of endoscopic suturing techniques is needed to enhance efficacy and ease of use. Our study clearly demonstrates that endoscopic suturing significantly decreases migration rate of esophageal fully covered metal stents. We believe this approach of endoscopic suturing of stents to decrease migration should be considered standard practice to enhance patient outcomes, reduce complication, and improve overall healthcare costs. On behalf of myself and my co-authors, I would like to thank GIE General for this opportunity. Thank you for your attention.